Today, a conversation with a surgeon, a professor, an ethicist, and a triathlete. That's one person, for Pete's sake.
Welcome to Coffee with Creamer, where you get to sit down with our host, Dr. Barry Creamer, for a conversation about faith, life, and culture. We'll look at old ideas through a new lens, turn those culture wars on their head, and paint a picture of the way things could be. If you like your thinking deep and your coffee hot, pull up a chair. You're in the right place.
And actually, it is one person that I'm talking to today. It's Dr. Allan Peetz. He's a medical doctor, a master of public health, fellow of the American College of Surgeons. He currently serves as an assistant professor of surgery, also with the Division of Acute Care Surgery and the Center for Biomedical Ethics and Society with Vanderbilt University Medical Center and the Vanderbilt University School of Medicine. By the way, I should say, the views he expresses here are not representative of Vanderbilt University. The thing I think is interesting, Dr. Peetz, about you is how much you've done and yet how much more you're trying to do. So first of all, just thanks for taking time to be on the episode with us.
Oh, it's my pleasure. I always enjoy talking with you. I always learn. I feel like I always walk away learning more from our conversations than I give to it. So no promises here. I'll probably take away more here too.
No, that's a very generous interpretation. I do think, the iron sharpens iron idea is something that I benefit from in our relationship. I always enjoy the conversations too. And that's why I wanted to share it with everybody. I've been telling you for several years that I wanted to get you to come on an episode with me just so people could hear the kind of conversations we have. It is true, right? You're still riding a bike and doing triathlons or stuff like that.
Yes. Yeah. So, I was able to influence my son, drag him along to do some triathlons. It was something I wanted to do a couple of years ago. I'm not naturally a endurance athlete. I actually grew up playing basketball and football, but like not these long distance runs. But I find that sometimes the spiritual community, I find it comes to me a little bit more when I'm exerting myself or drowning in the river.
That can be a spiritual experience, that's for sure.
Yes.
Yeah, we call it baptism, but however you want to refer to it, it's fine.
That's what it's.
By the way, I should mention to everyone, my encounter with you came through my son, Philip, a friend of yours, and y'all have ridden together. I ride a bike. Some of my audience knows I ride a bike, but I don't ride like Allan does, so I'm just saying to everybody else, I'm not going on a ride with him. Philip has told me how difficult it is to keep up with you, so...
that's very kind.
In fact, he kind of says he doesn't keep up. He just gets there later. So anyway, I enjoy all of that. I'm pointing all of that out right now, by the way, so that my audience can get a sense. So all of us can kind of get a sense. I get the sense you may have been a slightly competitive person as you were growing up. It's pretty ambitious, all the stuff that you're involved with. But most recently, you've taken up writing a few things, especially in an area where I'm really interested, ethics and in particular bioethics. And you've written a couple of things that I thought were really worth looking at for me. And I mean, all the stuff you've done is worth looking at, but I mean, for me, they apply to exactly the stuff I talk about with people. And you wrote an editorial, this was back in 2023, I think, that it came out in the Annals of Palliative Medicine. Titled, Does Thinking Make It So? What to Make of the Empirical Evidence on Moral Distress Among Surgeons. And I'm going to give you more time to speak in just a second, Allan, I promise. But and I'm saying that for my audience's sake, too, because they're like, shut up and let the man talk. I will. I honestly will. But there's a range of reasons that I have for wanting to talk to you on an episode. I mean, you have a career that's interesting to everybody because you're a trauma surgeon. And you have an organic, because of what you do, interest in ethics, and you're straddling a stodgy discipline like surgery between wildly different generations. You are, in my estimation, you're a millennial or somewhere in that range.
Yeah.
and you're facing the pressures that are familiar to everyone, but in a context that most would readily see as much more intense or challenging than what most of us are going to face in our daily lives. So, you're seeing on a regular basis, in reality, things most of us would undoubtedly prefer to keep, not even in the realm of the imagination, but in the realm of the unimaginable. And
Yeah.
I'm assuming there's a cost that's associated with that. And I think that's probably what prompted the article. So I want to talk through the article in just a minute in some of the details. But as I said, all of that, does any of that resonate with you or make you want to say, well, let me
Yeah.
put a different perspective? Go ahead.
Well, no, I'll add to it. I'll do the
Perfect.
what's that that rule in like when you do not stand up, but with the yes and kind of
Oh,
thing.
yeah, sure. Yes, and. Yeah.
I actually used I carried around a journal when I was a resident, in part because I mean I wanted to feel the things in surgery and well in medical school you learn to kind of be empathetic and you learn to to approach humans as humans because it's very dehumanizing kind of education because you're literally breaking people down into pieces or you're learning about their pieces like kind
Hmm.
of literally and figuratively, but at the same time when you actually do the actual job to kind of, this is going to sound counterintuitive, but to recognize people as humans in the moment is almost impossible. In fact, I'd say in sometimes it's actually unwise to do because you can't actually do the job. Like when I'm doing something like if I'm doing an ED thoracotomy where you have to deliver the person's heart in the middle of the emergency department to get it to beat again. I
Mm.
don't want to know about their hobbies and their human. I want to treat them like an object to
Huh.
get through it because they need me to get through it.
Hmm.
But at the same time, when later, like I found myself just getting kind of I don't know angry and also cold when I was going through residency, and I think that having the ability to reflect on those things, that's where I started writing. My father was a writer too, so I kind of lended myself to kind of knowing that that was a tool that I could use.
Ah.
And most of that stuff was just little journal entries that I would keep to myself. I studied ethics in college. I went to the University of Notre Dame, and I was an anthropology major. But we had a lot of philosophy classes that were required, and then I enjoyed that part of it. And so I learned a little bit more of like kind of the academic type of writing from college. And I've managed to get a fellowship in ethics when I was doing my trauma and critical care fellowship in Boston at Harvard, and that I mean I've turned it into a little bit of a career, I suppose.
Well, yeah,
So
I'd
that
say.
I added just to add some additional context of yeah, I mean it is sometimes I want to keep it unimaginable as well, but I find that the meaning is lost if you just don't bother to go through and reconnect with it in a human way.
Yeah, and it's just part of dealing with reality. By the way, just for my own benefit, I know you are a professor, an associate professor at Vanderbilt. Do you teach biomedical ethics there also?
Yeah.
All right,
Yeah,
very interesting.
so I teach a class on informed consent, and then I
Yeah.
also help teach a couple of classes in. We have a certificate in medical ethics that fellows can do. So a fellow is somebody who's in their final stages of super specialization
Hmm.
beyond residency, um, and I teach that class as well. And sometimes we talk about either justice issues. We tend to use a principlism type of
Yeah.
framework for discussing ethics in medicine, in part because it makes it a little bit more quantifiable. It makes it easier to ask questions about it. It does oversimplify things, and I think that we're getting into a stage. And part of the article that you were referencing is in reference to like how principlism is an oversimplification of how we view ethics in medicine.
Uh-huh.
It doesn't address that directly, but kind of indirectly, I suppose.
And this is, by the way, that explains so much because and I've done episodes before, so my longtime listeners will be familiar with when you say principalism with the ideas of autonomy, beneficence, non-maleficence, and justice. But it also explains why the other day when I was talking to you and I was saying those and I was just blurting them out, beneficence, non-maleficence, justice, and blah, 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 and you go autonomy. It's like
Yeah.
nobody ever does that, and so it's like, oh yeah, that's right. This is a list people know. Anyway, I
That was
really
fun for me too. It's always nice to be like, I know this one.
I loved it. Anyway, the point for me today is kind of talk through that article with you because it strikes on so many interesting different notes. I think for everybody. I mean, all of us want to hear it because again, there's partially a fascination with and help me know whether I'm saying this correctly or not. Your specialization is as a trauma surgeon. Is that a
Correct.
right way to say it?
Yeah, trauma or acute care surgery, because trauma surgeons often deal with non-trauma emergencies, so appendicitis or dead colons or things that
Ah,
aren't from stabbings or shootings or car wrecks or things like that. But I consider myself a trauma surgeon,
I got you.
and yeah,
That's it. But
but I
this is
also do
fairly
critical care.
fascinating. So you prefer somebody who's been stabbed, shot, or hit by a car. I appreciate that clarification.
Yeah, you're right.
So in the article, let's jump to the article. In the article itself, and again, I'll encourage Daisy will create a link for that so people can find it on our website as well. And the Annals of Palliative Medicine, you can find it, and you can just look up Dr. Allan Peetz, and you'll find it, Allan B. Peetz, as well. But anyway, in that article, you set the context with an experience you had with a particular actual gunshot wound patient. And I would love, I don't know how long it's been since you looked at that article, but I
No,
would
I
love
actually
for you to.
remember this patient very well. I
Okay,
know.
perfect. Would
Yeah.
you mind introducing that again for us?
No, not at all. Let me just say before we like
Yeah,
the
go ahead.
article that I want to make a shout out to the article that it was an invited commentary to an article that was a actual scientific study written by Dr. Millis out of University of Michigan, who's actually going to be at Vanderbilt soon, and was an excellent scientific study. So if people read my article, please read the actual scientific study that was commenting on, because it's an excellent study. And basically what that study was doing was studying this new concept of moral distress within communities that has been within the healthcare provider community. And we're still trying to define what moral distress is, which I'm sure we'll get into a little bit later in the discussion. But
Sure.
basically, the end of it was that the concept of moral distress isn't not a consistent concept within the academic literature. And they thought that Dr. Millis and his colleagues who wrote the original article that I was commenting on um, uh, um, did a really great job. So just
Yeah, and
endorse
I
that.
appreciate that. And by the way, I just want to mention that in case I don't say it later on, I think the nuance with which you approach the topic in your article deserves a little credit also, because there's not a wild swing of some moral claim that you're making, but instead just an effort to get people to think more clearly and more precisely about what exactly they're talking about.
Yeah, that's what writing is all about. I think.
You would think, wouldn't you?
Yes, you would think. You would think. That's
In
the
our
exercise.
culture, I'm not sure it's going that direction, but I
No,
appreciate that you are.
you're probably right.
Okay,
Well,
so
so
this
the
patient, yeah.
case you were representing, yeah. So it was a man in his 20s who was shot out in the middle of the street, did not have any ID on him, and was brought in after some bystanders called the police, and I think he was brought in by an ambulance. He didn't have any ID, didn't have anybody who knew him, was just found on the street and was shot in the head, and was brought in. I saw him in the trauma bay because I was on call that night. And long story short is that he progressed to brain death. Was I had to
Right.
declare him dead about 12 hours later. And usually in the ensuing 12 hours, usually you get like they're the social workers and the police officers, and they're usually good at finding out who people are. And even after 12 hours, we had no idea who this man was. And I call him when traumas come through, and partly for security purposes, they get assigned a name, and it's at Vanderbilt, it's stat something. Sometimes it's trauma, comma, they use just the word trauma for their last name, and then it's some sort of random. It's not a number generator; it's just a word generator. And I don't remember what his was, but I think in the article, just to be kind of tongue in cheek about the whole thing, I used the stat dilemma because
Yeah.
of the conversation in the actual article. Um, but he came in and I declared him dead, and we didn't know what to do about him. And partly one of the issues that we have with people who are especially brain dead is that they're potential organ donors. Um, but I'm not in the job, I'm not in the career, or it's not my responsibility to be a transplant. I'm not a transplant surgeon. I don't have any incentive, nor do I have any inclination or moral responsibility to the patient for that individual, like, goal of saving organs. But there are societal benefits that there was some hope that we could find some people who would less whether or not he wanted to be an organ donor. And also there was also, just for me, some moral dilemma of taking this person off of life support. Although he was officially dead, we still sometimes give the family time to come to the bedside before we remove them from the breathing machine, the mechanical ventilator, and take them off the monitors.
And
And I end up having to do that
I would
by
imagine.
myself.
I just want to pause you for a second to go back on two or three of the things you just said, because you were running through big ideas that a lot of people, I don't think a lot of us have thought through at all.
No, yeah, please.
One is, I'm assuming, have there been times when you've been able to delay a final decision about, declaring someone dead or whatever, however you would define that, but you declare someone dead, you've been able to put that off long enough for their family to get there? And
Yes.
spend some time with them. Have you seen? I know you're just giving an opinion here, but I'm just, you have the experience and we don't. Does it help when people get there before the patient has died instead of coming afterwards? It seems like that might. I mean, it would be tough to know whether that would add to the stress or if it would. I don't know how you would take it. So, what's been your
Yeah,
experience with that?
yeah. So, like a lot of things, I think I would say it depends. I mean,
Mm-hmm.
my inclination is to say yes, it does help. It also helps, I think, for people to be able to say, this sounds kind of crude, but it in my experience, it's true. People have a it's easier for people to say goodbye to a warm body rather
Ah,
than a cold.
yep.
And so, like, so what we when you can declare death by two, like either cardiovascular death where the heart stops, or brain death where there's several different criteria for brain death that is kind of outside of the scope. But there's a criteria for declaring brain death, but either one is both medically and legally dead. In this case, it was brain death for this particular patient.
Right.
But there was that I have you have kind of, you're using
Yeah.
resources in order to keep this body, like,
Warm.
perfused and warm, and in hopes that you can find somebody. It also just feels a little bit more, I don't know, dignified,
Yeah.
in a
Mm-hmm.
way, for
Sure.
the body, the human that I'm responsible for, because I was that man's doctor. And I
Yeah.
couldn't do anything for him, but I had a responsibility to him. Do I still feel do I, and this is debatable, I think, and actually it's probably an interesting academic question to ask, is like, how much responsibility do I have to his body afterwards? And I think that there's some responsibility, right? Like,
Oh yeah.
we have a responsibility to treat human bodies and human remains with dignity. But is my time, when I'm being pulled in multiple different directions, is the correct use of my is the morally responsible use of my time best spent at the bedside with this dead body,
Yeah.
or is it at the down in the ER with the next person who gets shot, who needs my attention? And I think it's the latter. I mean, I think that that's what
Sure.
but that doesn't mean they have no
Yeah,
responsibility.
it doesn't
It's
mean
just
there's
a matter
none.
of
And
degrees.
there's
Yeah.
an interesting Russian statement. I've forgotten the exact author who penned it, but you may be familiar with it. That if you want to understand the ethics of how people treat their living, then you should look at how they treat their dead.
Mm,
Yeah, there's
it sounds like Dostoevsky, but
it
I don't
does.
know.
That's exactly who I was going to say it was. I'm not quite
Yeah.
positive though, but I'll look it up in the meantime. We'll put it on the website too, so people can find
Okay.
it. But there are other quotations about that come from World War II that have the same kind of implications. Anyway, my point is,
Yeah.
I appreciate you taking time to say that. The other question that your conversation provoked just a moment ago was, when you're, and again, I just want to clarify this and pause for a second, give people a chance to process it. When you're talking about the dilemma between, this body that's in front of you and is dead or dying, and the organs that are in it being transplanted to someone else, that someone else is not your patient. This person is your
That's
patient.
correct.
And as a physician,
That's
you have a
correct.
primary obligation to your patient. The reason I'm bringing this up for a second is that you also are a master of public health, and public health has different considerations than just
That's
the
right. Yeah.
individual patient in front of you. So if you wouldn't mind just expanding on that for a second. You did some, but I'd just like to hear you talk about it for another minute.
Yeah. So, I mean, I think so. My master's in public health doesn't drive how I practice medicine, and I think
Uh,
the way that I would approach this person, I think that the dilemma that we all face is kind of the same, which is it's possible that this person would really want to be a organ donor. You just can't ask them at the moment because they're
mhm.
dead. And so, in some ways, like withdrawing life-sustaining therapy before you have a chance to find out whether or not they would want to be an organ donor, which is best assessed by a surrogate decision maker, which is usually a family member, um, is you risk you run the risk of essentially stealing that opportunity from somebody who would really want it, right?
Mhm. Mhm.
But at the same time, you're also utilizing resources for somebody who may not want to do that, and you also don't know that. And so, giving yourself an opportunity to kind of this is the way that I frame it, because my responsibility is to the patient. It doesn't really matter. Like my responsibility isn't for that. They're not imaginary. They're real patients, but they're not my patients
Right.
who are waiting for an organ. Donation. I don't have a responsibility to that person, and I think that people who get mixed up in thinking they do make it very difficult to actually manage
Yeah.
their patients or the patient's families effectively. And I separate those two things completely.
And I appreciate that.
Um,
We should have another conversation another day. Maybe when when I'm in Nashville and I get to just have a
yes,
conversation with you
please.
about the difference between one person trying to represent the whole of the system and the need for a social setting. So, meaning having another physician that represents another patient, and the interests converge in a conversation that you have with each other, in which competing interests can have a fuller expression. Anyway, that'd
I'll
be
tell you, I know though that will delay that, but my not totally thought out, and I'm not sure I could defend this fully, but I think that the best answer to this question is that the entity that advocates for the imaginary patients needs to be the organization, while keeping the physician
Mhm.
at the bedside
Mhm.
focused on the patient.
There you
But
go.
that's my half-baked opinion right
No, it
now.
makes sense. Half baked is good enough for today. That's what we're looking
Okay,
for.
perfect.
So I do want to ask a question on the way to the main topic. We haven't quite hit the main question yet, except you mentioned it just briefly at the beginning. So and I'm asking this for the reason that will lead to it, even though it may not sound like it. You mentioned you were the physician on call, or you the surgeon on call.
Correct.
So just before you were, just so people can understand where you're coming from, but also so they'll know where your psyche was before you started this. Just before you receive a patient like that gunshot wound patient that you had, trauma dilemma, I think you said was the name
Yeah.
you were giving him. Are you doing administrative work in an office down the hall? Are you watching a game in a doctor's
I was
lounge? Do
actually
you
in my
cut out early from
office.
your kid's school talent show? I mean, what's going on?
No, I was actually in the hospital. I think I was actually in my office doing some notes on another patient or looking at a CT scan for another patient
Uh-huh.
when that trauma page through. I don't remember exactly, but no, when you're on call for trauma, you're actually in the hospital. A
Okay.
big level, big busy level one centers. The trauma surgeon is actually in the hospital at all times,
Which
24/7,
and I but
365 days a year.
as an outsider who might need trauma care at some point, I'm
Yeah,
pleased to hear that. That sounds
yeah.
encouraging. Um, so I'm asking that question obviously because I think the kind of boundaries you have between that crazy liminal existence you have right between life and death all the time in the hospital where you do your work and the life you have with a family and kids and all the triathlon stuff and all that, it seems like that could be really important to maintain. And I'm not even sure it's possible to maintain fully. I don't know that you could do your job and not always have it on your mind. Is there a line you have between those two worlds in your own life? Not trying to invade your personal life. I'm just curious.
No, I don't feel invaded at all. This is a really great question. As I have gotten older, I have been able to draw that line better.
Hmm.
I would say that, like, as I think I took those things home with me more when I was younger. And I think that it's not that I care less, it's that I think that I have found that carrying those things home, I think I think you run into this delusion that you can solve it, you can figure it out,
Mm.
and that, like, if you just think on it a little bit longer or pray about it or meditate on it or whatever verb you want to use, that you'll be able to figure it out. And I actually find that space is better for
Hmm.
those sorts of things, and realizing that sometimes it's just you did the best that you could and there is actually no right answer. There's just the best one that you couldn't come up with
Yeah, and so
at
and
the time.
that particular issue right there is what your article hits on that seems so important, and you raised it in a way that's uh, not spelled out in the article, at least that you wrote about the psychological risk that's associated with surgical judgment, and I mean by that you mentioned the difference between, and I don't know the right vocabulary here, Alan, so you'll have to help me with it, but the difference between medicine and surgery when you're doing a morbidity or morbidity discussions, after someone has died. Do you remember what I'm talking about? Would you mind
Yeah, so
mentioning
there's
that?
a quote that that I took from Charles Bosk from a book he wrote on To Forgive and to Remember, as a sociologist who actually did his sociological research embedded in the residency program at University of Chicago. Coincidentally, I also did my residency. It was it was years and years before I was a resident. But one of the things that he wrote was that in comparison to a medicine service, and we're talking, what he was talking about was these morbidity and mortality conferences that all surgical services and medicine services have, where you go over the complications and the deaths that happen on service, and you try to learn from them, and you go through what happened. And what the point he made in contrasting the difference between a medicine doctor and a surgical doctor is that at these morbidity and mortality conferences in medicine, the fundamental question is what happened. And in a surgical morbidity mortality conference, the fundamental question is, what did you do?
Mm.
And I think the point behind all of that is that, like, we take our 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 wins, our losses, our complications, um, really personally, because we're personally involved in inflicting the treatments on our patients, which necessarily come with some harm because
I want to make sure I heard your sentence correctly. I kind of missed one word, but it sounded like you said we inflict care on our patients. Did I hear that right?
I, I did that on purpose. Yeah,
Yes.
I mean, because as a surgeon, the tool I have is a knife, and so, part of what we do in order to help people is that we cut. and we cut things out and we sew things back together, but there's some harm that happens in the actual care that we give, and hopefully that's minimized, and it's balanced by the benefit that we hope to gain out of it, but there's always some risk that goes along with using a knife in order to help people.
Yeah, and I can imagine. I don't know. I don't know what kind of person looks at a career and says, I want to spend my life cutting open the bodies of human beings. Um, you seem like a decent person, though, in all the
Yeah,
times that I've met you.
I've got you fooled. I've got you fooled.
Yeah, well, so I guess I mean there's an inherent difference. I know I hear people say this between, and again, I'm just not in your world at all, but between, I mean, you're a medical doctor, but a surgeon, and then there's a way you talk about medicine and surgery that are different that I think a lot of us just don't think about the significance of that difference, that your job does entail inflicting care on someone, with a knife. And so there's a psychological risk that's associated with that. Not to the patient. There is to the patient, I'm sure. I mean, I know it would be to me. But the risk to you as a surgeon when you're taking out a knife to harm someone in order to help them. Would you mind expanding on that for just a moment? Because that's a big part of what your
Yeah,
article is about.
yeah. So one of the things that we're trying to parse out in the academic literature is what is this concept of moral distress? And I take a little bit of issue with the idea of moral distress because what you're describing is what I think one of the definitions of moral distress is that you have this great power to help people, but it also comes with this risk of harming them. And with technological advancements and with all of the things that we can do in medicine, we can do a lot of different things in medicine. It's just about whether or not we should. And I think that in the literature we've been calling things moral distress in part because I think sometimes we're asked as not just as surgeons, but that's what the article was about, but in the medical community to do things that we're not necessarily in line with moral values.
Hmm.
Now, some of the training of becoming a surgeon, I think it feels like it's not in line with your moral values, but you realize that it's necessary to do so. So I think the example that I gave you is that one of the more traumatic experiences I have had as an intern was inserting a chest tube into a patient who was awake but dying because they needed their lung to be decompressed. It was psychologically kind of distressing for me to inflict a large amount of pain on this person in order to save their life, but they needed to have it done. And there was actually no time to do anything else other than to do exactly what was necessary, which was to shove this large tube into this man's chest in order to save his life. That fits one definition of what original articles, that scientific article had studied one definition of what moral distress is, just that moral distress sounds like a disease that needs to be treated. And one of the issues that I have is that it's actually, at least not in my experience, not wholly not true. I mean, learning
Hmm.
how to do those things in the most compassionate way possible, but realizing that there is some suffering that happens both on the provider's part, but also on the patient's part, is a part of the learning process. And I'm not trying to advocate for pain and suffering. I'm just also advocating that that's sometimes part of the process.
Yeah, well, and I assume for a surgeon especially, I mean, basically accepting the role of surgeon is accepting the role, like you said, of inflicting care. So I don't want to make light of it either, and I'm going to ask you a question on quite the opposite side in just a second. But I mean, I'm assuming part of your assumption is, hey, you just ought to sort of buck up and do the difficult thing because that's your job. And again, I'm not going to stick there, but is it at all like that? What you're saying?
Yes. Yeah. I mean, somebody might go, right. Yeah. I mean, I think that that's true sometimes. And I think that there has been, there, it's not true all the time. And
Right.
like
Hmm.
I think that historically we have used the like toughen up and like or like in the most like juvenile way of just like be a man or whatever. Like that's old. It's boring. It's untrue some of the time. But it but that said, sometimes I mean part of what makes the job meaningful is that it's hard. And being a doctor, being a surgeon is hard sometimes, and it's hard to do what the right thing sometimes, and sometimes it does seem like you're doing the wrong thing, but you have to learn from experience and use your judgment. But like sometimes what is morally distressing is actually the right thing to do. Which actually what one of the that I was trying to get to with the point of the article, which is I'm a little bit worried about the concept of moral distress becoming so kind of just commonplace and unquestioned that we're going to start to avoid doing the right thing because it's distressing to do when it's actually the right thing to do.
Let me ask you something on the opposite side for a second. Again, as a complete outsider, but I've known a few medical doctors and a couple of surgeons, and I've known some policemen, and so there's a parallel
Mm,
in the concept of the desensitization, that goes on over time. Again, when you're seeing in actuality things most of us just don't want to imagine are true. We just don't want to know that could happen,
right.
and you see it day after day after day, and it becomes your routine. How, how does that affect you? So let me put it in these terms, Allan. How does that affect your reentry when you're willing to do it? And again, I appreciate the fact that you're trying to remain a human and treat other people with empathy, but also be able to look at them as an object in that moment when you're trying to fix the machine that's broken. I
Yeah.
understand you're saying all of that. How does it affect your reentry into the mundane life? And I don't mean that insultingly. Just you know,
No.
waiting for you after hours in this liminal existence you have. So yeah, yeah. Go ahead.
Yeah. I mean, I think that's changed over some time. Like, who would be probably the best person to ask this question is my wife, but I'm not going to let you do that. Well, that would be too honest, probably.
That would be invasive. Yes.
That would be invasive. Yeah, that would be just too honest. At least I can make something up with you here. Yeah, uh, I think, when I was younger and I was taking things home with me, I think that I was hypersensitive to all of the wrong things that could happen
Hmm.
in mundane life. And I think just with some time and with people around me, and including my wife, I've had some help in actually learning that it does affect me, and being aware of that. I think I've gotten better with it over time.
Do you
I'm
know?
sort of dodging your question, but I mean that's the best I could come up with,
Well,
I
you may
guess.
want to dodge this one too. I'm
Okay,
really not
perfect.
asking them to put anybody on the spot. I just don't know myself. And like you said, there are scientific studies that are addressing this and trying to get actual empirical evidence on whether it's the case or not. And I'm assuming this would be a version of that, but more maybe on the human side. Do you know surgeons? And I'm not asking about individuals that you could name or
Yeah, of
something
course.
like that, but do you know surgeons who have turned off their humanity and you think, yeah, this is a person who really just doesn't regard, people as people much anymore. They're going through life with that part of their empathy turned off, that they've become too desensitized. Or is your experience more, no, they learn to walk away from it at times and just go back to being an empathetic human being? Eh,
So I don't know anybody who has just completely turned it off. I think we all, as like, especially in my group, where like I have a lot of great partners, and they're all great, honestly, great humans. I learned a lot from them. I think that we all learn to kind of read when, like, I mean, sometimes we go on stretches of being on clinical service for long periods of time,
mhm.
and I think that we're all good at kind of checking in on each other, and like either deliberately or just kind of it just happens naturally because we all know that the job is hard.
I,
Honestly, I think that having kids And
Uh,
such a, I mean, that sounds kind of selfish. That's definitely not the reason to have kids. But I think there's such a humbling experience of being a dad, and also they're such mirrors to who you are,
uh,
that they kind of reveal. At least this has been my experience, that uh, being a dad kind of reveals those ways in which, like, you've gone too far into the abyss
yeah,
sometimes.
yeah, I hear you. You see them staring back into the abyss.
Yes,
um,
exactly. Yeah.
the last thing I really want to ask you about is, among the surgeons, doctors, students, I'm not sure which group you would put them in, but the ones who are saying, "Hey, I need a break from this uh, moral distress that I'm facing," to use that language. I'm assuming those are younger, that they're in the younger generation. Maybe
Usually.
just because they're just coming into the practice, but also maybe just because that generation thinks differently about life. Is that your experience?
Yeah, I mean, like, that's definitely. Yeah, I mean, I think so. There, that the reluctance you're hearing in my voice is that, like, it's so easy to be that surgeon who's like, back in my day. And like, I'm gotten older, and as my son has pointed out, my hair is getting grayer. I don't consider myself old. I mean, I've been doing this for over 10 years, which is a decent amount of time. It's just
Hmm.
that, like, there are people who've done it longer than me, for sure. Obviously, just in my group. But I think that I would like to avoid being that guy who's like, back in my day. Um, I
Yeah.
do think that I do think that people walk in, the trainees come into it not having been fully exposed to it, and then don't realize the moral dis- the we'll call it moral distrust, even though I
Sure.
made making the argument that we don't even really know what that is. Um, but, like, the distress or the psychological turmoil that goes along with that, and I don't think that they fully realize what that is. And I think that as trainers, or as, like, educators in it, I think that we need to be mindful that the job is hard, and that if you take it seriously, it can lead to burnout pretty quickly.
Yeah, perfect. I again will encourage everyone to go and actually read the article, look at the article, and as you did, to go back and read the scientific study that provoked you to write this. And we'll put links to both of those on there. Alan, you may need to send me the link to that
Oh yeah,
scientific
absolutely.
study again. But the and it's mentioned in the article, so I know you can get it from there as well. But I just want to pause and say thanks for the work that you do, all the effort that you've put into getting the qualifications and the certifications, and the decade you've put into doing that kind of work. Because even though we're not holding parades for you and doing all that kind of stuff, the fact that I could have, a knife or a gun or a car change my life, but you'd be there waiting to fix me, is a pretty handy bit of knowledge. So I really appreciate the work you do, and thanks for taking the time to meet with us today.
Oh well, I'm honored. I'm honored to be the one who's ready to help, but I hope that will never happen.
Yeah. Well, thank you for the sentiment. You're still
Yeah.
human. You're hanging in there. Way
Yes.
to go. All
Hanging
right.
in there. Yeah.
Dr. Allan Peetz, thanks very much. God bless.
Thank you.
Thanks for joining us for Coffee with Creamer. Your cup of coffee may be finished, but we are not. Come back next week for a refill as we sit down to examine a new set of ideas and cultural issues. Don't miss an episode. Subscribe wherever you get your podcasts or visit our website at barrycreamer.com. Until next time, keep your mug hot and your mind sharp.